My name is Heun. I'm a consultant psychiatrist and professor of psychiatry, and today I'd like you to learn something about the treatment of acute manic episodes. So first I'd like to remind you what a manic episode is. It's when someone is very agitated, can't sleep, might be aggressive, might feel they have great powers, might be very strong, thinking about himself, might be feeling that he's a great person, might be that he can, whatever, is someone who has a religious power or specific powers. Or I recently had a patient who said she could fly, and they could read other people's minds, and they might usually not be seen in hospital, but that's why you usually treat them. Very often they're brought by family because they're very agitated, aggressive, or they're brought by the police because they have been seen in the public and might have been very challenging and aggressive to others. Right, so if someone's very agitated, talks a lot, shouts a lot, then you might see an acute manic episode. And if people have a very severe agitation and might not respond to calming them down with talking, you might have to give some medication. There are usually two medications now the learning starts. There are usually two medications, which are benzodiazepine, could be diazepam or lorazepam, which usually calm down, or it could be an antipsychotic, which also helps in case people have manic ideas and or psychotic ideas, which are stressful to them or stressful to others. In some patients where there is no chance to give a medication, for example, if they're pregnant or have severe heart problems, then ECT might be available. However, usually the preparation of ECT and all the physical health stuff very often is not available, at least not in very acute stages. If they are currently on an antidepressant medication, so if someone has an antidepressant, he is in hospital or she is in hospital, you would usually not continue the antidepressant, or you might swap to alternative medication and wait for the antidepressant if it's needed again. As one often sees is that people who have a manic episode after their episode, even if treated, they're worn out, and very often they start having a depression. If they've never been treated, they're very agitated, then you would try an antipsychotic, a sedating antipsychotic such as olanzapine, quetiapine, risperidone, or haloperidol, which is a bit of an old type antipsychotic. Sodium valproate or lithium might be second line if people have a history that they respond to that medication. If people are very agitated, you can't start with a very low dose. Usually you start with a middle dose. For olanzapine might be 10-15 milligrams per day, quetiapine 50 or to 100 milligrams BD. However, it's extremely sedating. Currently, there is some modified release version of quetiapine available, which is in a dosage of 300 milligrams, so that might be an option. Risperidone is an option. Aripiprazole are also options which are available. Usually olanzapine and quetiapine are more sedating than other medications, so they're usually the first choice. If people have other medication already and they are on lithium, usually not in the most acute stage, because lithium wouldn't work that fast, so it might take some time. But if they're already on lithium or sodium valproate, you would try to increase the medication and then consider whether you need some other medication on top of that. If people are on an antipsychotic medication on high dosage, then very often they have stopped the medication, they were fine. And one of the things which convinced me about that antipsychotic medication is helping was that if people stopped their antipsychotic medication, they very often had relapses. Right. So lithium might be an option, but usually it has a very slow or delayed effect. So you have to combine it possibly with a benzodiazepine, and that might be an option. You could combine it with sedating antipsychotic. So that might be a chance. Sodium valproate is very sedating, can be easily combined with other medication. However, there's a big catch that in patients or even in men who are in childbearing or child-producing age, then this medication might be contraindicated, as it might lead to toxicity of the unborn child, even in very early stages. Benzodiazepines are medications which can be used easily. They're very often used, and they're combined with other antipsychotics. Usually you could try haloperidol if people have a history of good response, but if at the moment, if people haven't been treated before, you would possibly go for a more sedating second-line antipsychotic, such as olanzapine or quetiapine. Carbamazepine is another option which can be tried if other medications have no good outcome or people don't respond. It's an anti-epileptic which can be given up to 800 milligrams, but it's nothing on first line. Then the other option are other anticonvulsants or anti-epileptics. Lamotrigine, gabapentin might be given in acute mania. Usually you would have this choice if people have already made experience with this medication, and then they might have a chance and to say, this is what I usually responded to, and then this is usually the first line. So that applies to all of the experience, that if patients have responded to a medication, they're more likely to respond to the same medication, and then you wouldn't try a new antipsychotic or a new anti-epileptic. Clozapine is also very sedating and could be tried, but due to the fact that it takes some time to titrate it from a low dose to a high dose, then it's usually not the first line medication. Right, so the take-home message is, if it's necessary to treat someone with acute mania, the first line would be a sedating antipsychotic, and then you go with the experience of the patient. And then you just try to, from the physical health side or from the guidance of the patient, you try that they calm down, have a quiet environment, they're not challenged, there's no aggression, there are no arguments, and this is what sometimes hospitals can provide, a quiet environment where the people are used to some challenging behavior, but they wouldn't challenge the patient and make him agitated. I hope you learned a little bit, and if you like, please subscribe to our channel, Global Psychiatry Archives, and if you really like it, you can give us a message and tick the appropriate box. Okay, thanks a lot, have a nice day, and I hope this is interesting for you. Thanks a lot.